Good afternoon, everybody. Good afternoon, everybody. I just wanted to welcome you on behalf of the Yale School of Public Health to our panel today. My name is Greg Gonzalez. I'm an associate professor of epidemiology at the Yale School of Public Health in the Department of the Epidemiology of Microbial Diseases. This is part of Ed Yong's Poynter Fellowship in Journalism at Yale. Some of you were with us last night when he gave a talk at the Yale Law School under the auspices of the Global Health Justice Partnership. It gives me great pleasure to introduce our three deans, and then I'll let Ed introduce himself. Amy Fairchild is the Dean of the Ohio State University School of Public Health, and she's a historian who worked at the intersection of history, public health ethics, and public health policy and politics. Her work helped establish public health ethics, which is concerned with the well-being of populations, as fundamentally distinct from either bioethics or human rights. Dr. Michelle Williams is the Dean of the Faculty of the Harvard T.H. Chan School of Public Health. Dean Williams' scientific work places special emphasis on the areas of reproductive, perinatal, pediatric, and molecular epidemiology. And finally, Sten Vermund, the Dean of the Yale School of Public Health, is a pediatrician and infectious disease epidemiologist focused on diseases of low and middle income countries. His work on HIV and HPV interactions among women in the Bronx methadone programs motivated a change in the 1993 CDC case definition. And then I'll turn it over to Ed, and here we go.
Hello, everyone hear me? Yes. Great. I am Ed Yong. I am a staff writer at The Atlantic, where I've been covering the pandemic. I am Dean of nothing, and I'm delighted to welcome you here to the great Yale Dean Off, this Dean-a-thon that we have going on. So this event was pitched to me as a panel responding to a piece that I wrote last year about the extent to which public health has participated in its own marginalization. So in the piece, I argue that in the early 20th century, public health had several qualities which had become diminished over the last century of events. More of an understanding that people were susceptible to disease because of social problems like dilapidated neighborhoods and crowded housing, unsafe working conditions. It had more of a crusading spirit, and that fixing those problems required social reform, and that was a central and whole part of the field. And it worked in broad social coalitions. There wasn't really that much of a field to speak of. The rise of germ theory, of this vision of disease, is solely the battle between a host and a pathogen, led to the downplaying of many of those qualities. In 1913, Hill wrote that the old public health sought the sources of infectious diseases in the surroundings of man, while the new public health finds them in man himself. This vision gave people license to avoid the kinds of sticky social problems that I was talking about, and move away from the focus on social reform, which was seen as inefficient or overly political or misguided. So over time, the field narrowed in its focus, in its work, and in its ranks, cleaving to this biomedical paradigm at the expense of its own political power and the kind of alliances that were giving it strength. Some of that has been clawed back. The rise of the field of social epidemiology, a greater appreciation of the social determinants of health activism that arose after the emergence of AIDS. But we're still in a situation today where the spectrum of individualism looms large over the field. There is still a strong emphasis on this biomedical paradigm. The field remains underfunded, and it has been, over the last few years, accused of being too political. Several of the people I talked to in this piece argue that, in fact, it is inescapably political and needs to embrace that fact. As Daniel Goldberg said perfectly to me, science is not a product, it is a practice, which means it is a thing we do, which means it is social, which means it is value-based and political, the end. So I argue in this piece that public health needs to recoup some of that diminished crusading spirit, embrace its inescapably political nature, form broad coalitions, again, advocate social reforms rather than lapsing into further iterations of panic and neglect cycle. So that sort of framing where that sort of provides a framework for this discussion. Obviously, that piece was a 1,500 word attempt to capture 100 years of history that I then tried to crunch even further into the last 5 minutes of spiel. Safe to say, I missed some stuff. So I'll stipulate up front, this historical narrative, as they all are, is incomplete, and especially when dealing with a field so varied and diverse as public health. What I want to get into today is not just to get lost in debates about what public health is, or to binarize this question in terms of like, has it lost its way or not? I want to start by hearing from our Tri-Dean crew about the extent to which you agree or disagree with this framing. What parts of this narrative do you think capture something real that you felt over the last 2 years or more, and what parts, what bits are missing? Amy, do you want to go first?
Sure. Can you hear me? No.
There we go.
Now? Okay, yeah. So thank you, Ed. And I think I'm officially now the dean of quarantine on the OSU campus. So when you say that, please say it with love, not with rolling eyes or foam coming out of your mouth, which is sometimes how I hear it. So I do think, Ed, that this maps on to the argument that me and some of my colleagues have made, and I'll give you a really good example. So in 1939, there was a national health insurance bill, and you had some of that old coalition of reformers, housing reformers, labor reformers, who were backing this bill. The NAACP were backing this bill that. Okay, is this better? Can you hear me now? Okay, all right. Yeah, but but this is just my voice, right? Okay, all right, okay. So you had some of these same reformers, housing reformers, social reformers, labor reformers, backing this national health insurance bill that wasn't about paying for health insurance, that wasn't about paying medical expenses. It was about replacing people's salaries. It was about ensuring that Black workers had the same salaries as white workers. So it was really very much about social equity, and public health was nowhere to be found in that conversation, because by that point in time, as a field, we had really turned our eyes down to the microscope because of this infatuation with science and this belief that science was going to allow us to purchase population health. It was going to be cheaper. It was going to be more effective. It wasn't going to require the same kind of difficult political sweeping change. But I think it's also important to underscore, as we fill in some of the pieces of this history, that there were some contextual factors that made it very hard for public health not to go down this pathway. And there were some factors that were actively working against the field of public health. But I still think it's important to think about our choices as a field at this moment in time, because this is a moment in time in which there are attempts to stifle academic freedom in the form of bans. I'm talking about critical race theory that are cropping up in different states, including my own. We now have don't say gay bills in more than one state. We have attacks on public health officials and public health professionals, deans, people who have spoken out, have experienced this. It's a moment of limitations on women's reproductive choices, citizen surveillance, and bounty hunting, and this extends to the parents of trans youth. So as a field, we need to be aware of these forces, but we also need to think about our past and the choices that we as a field that have made that have limited our reach. So the thing I would stress is, though, let's think about our past too. I would look at the moment in the 1920s, so that this period after the heyday of public health, the progressive era. It's the period of the Palmer raids, of the Sedition Act, of the Espionage Act, of the re-energization of the Ku Klux Klan. It's one of the periods in our history that's seen more lynchings than any time in our American history. So this is a period of time which became difficult to advocate for social change and social reform. It's a period of Hooverism in which private business was supposed to be doing a lot of this work. And so there were a lot of forces pushing back against public health too, which made going into the laboratory looking at bacteriology very easy. And it's also in a period in which the American Medical Association begins to activate and talk about socialism and anything that involves paying for health insurance, anything that involves public health having a bigger role begins to get critiqued as un-American. And of course, then in the 1950s, that was very dangerous for public health as a field to talk about class, to talk about race, to do anything that challenges the social order and the affluent society. So those are the forces that push back against us. And then we have to think too about how funding affects our priorities as a field. So since 2008, the NIH has more than doubled funding that's directed to efforts to look at health disparities. But still, in 2021 and 2022, for genomics, clinical care, biomedical research, there's more than double that amount of money that there is for prevention. So there are still a lot of forces working against us. But I think what this gives us, what history gives us, is the opportunity to think about different possibilities at a moment where there's a lot of potential, because I think we are coalescing around the Black Lives Matter movement. We are moving context, we are moving the social determinants again to the center of what our field is and what our mission is. But it's also a moment of peril for our field.
Thank you very much.
Sorry about the.
I'm just going to shout when
I'm sorry about the sound challenge, but I'm seeing chats that people are getting a lot of echoes. So let me hold this away and do the best I can. So I'm going to get a little autobiographical because I knew I was following a historian and I couldn't compete with that perspective. But from about 1985 to about 1994, I was working in New York City and then at the NIH, and there was an unapologetic mission to control the HIV pandemic. It was just what we did, and there was an overlapping Venn diagram between our research, our teaching, and our activist mission, and there's just no question about it. In 1994, I left government service and went to University of Alabama, Birmingham, and where I was chair of the Department of Epidemiology. And I walked into a department.
You need to
Hold it up. Oh,
that mic should be okay.
yeah. Okay, is that better?
Yeah.
Okay. So moving into that department, prior chair, the very famous epidemiologist, world renowned, had a very strong philosophy that I was reminded of when I read and reread Ed's article. And that was that epidemiology was observational research and should never get involved with intervention. And that literally was the philosophy of the department. And of course, I had a very different philosophy, and a very different perspective. I had nothing against the clinical trial, which was interventionally oriented. I had nothing against the policy leap from observation to policy intervention. And it was a challenge because half the department agreed with me and half the department agreed with my predecessor. But it was very much a political struggle as well, because there was a very different political philosophy in those two camps, if you will. I remember having a conversation with a faculty member who said, I've been asked to do a review of the Medicaid policies of the state of Alabama. Now, Medicaid in Alabama is, by all accounts, one of the worst Medicaid programs in the country. It's underinvested, it's poorly run, it gives very poor return on investment compared to many other states. And I said, well, that's terrific. I'm so excited that the Department of Health has asked you to do this. He said, oh, no, I'm not going to do it. And I said, well, why aren't you going to do it? Oh, it's much too much work. So this was the public School of Public Health turning down a contract with the state health department to study supposedly our comfort zone, the Medicaid program, and see how that can improve or reform. So it was a terrifying moment in my career, in the sense that I saw academia almost in the way of progress. Now, I think we were able to make an impact on that department. I think we were able to make an impact on the school. We were able to build stronger ties to the state health department. We were able to turn it around, but that's the context in which I think Ed and Amy are discussing the retreat of academic public health from public health activists. And fast forward 23 years to my arrival here at Yale, we had some work with the Department of Public Health in our state, but it was fairly limited. We had an Office of Public Health Practice, but it was very small. And our students were clamoring for more opportunity for what I would call relevant placements, placements that were going to enable them to do their internships and actually contribute to making a difference. So we've tripled the size of our Office of Public Health Practice. We've anchored leading faculty into that office. We have an extraordinary executive director of that office who is a graduate of our school, but came to us from community anchored jobs previously. And I think we were better prepared for COVID than almost any part of the campus, because we had revitalized our Office of Public Health Practice. Our students were demanding opportunities, and the university turned to us for a whole host of issues, whether it was helping the food insecure or whether it was contact tracing for the city or whatever it was. I think we were in the next position to respond. And I'll just end by saying, engaging with civil society, the ability to communicate public health principles and policies is, to me, a vital part of the education of each and every one of us. And it's lifelong education, because I can do better, you can do better, Ed can do better. We all need to do better.
Especially,
Not at all, you're doing great. And I'll just end by saying that the politics, I agree completely that public health and medicine, for that matter, are political. If you have a deteriorating sewage system and you're going to be contaminating your freshwater supplies, and you have to vote to invest $30 million to reform that, that's a political decision. You have to vote, right? But I'll tell you, the partisanship is more dysfunctional today than I've ever seen in my entire life. It was quite common 15 years ago for Sten Vermund, who has one political philosophy, to work closely with Bill Frist when I was at Vanderbilt, who had a completely different political philosophy. We worked together seamlessly on a host of public health challenges. And you're seeing that happen less and less over time. It's become more partisan, where sure it's political, but we used to have people from all walks and perspectives in favor of public health. And now public health seems to be almost the socialism split that you alluded to, that if you are in favor of addressing social underpinnings, the social determinants of disease, if you believe that climate change is an existential threat for our children and our grandchildren, if you believe that wearing a mask in a school where COVID is still raging is a logical and respectful and courteous thing to do to protect the public health, then you are somehow on the other side of the partisan divide. So we've got to fix it, and I'm looking forward to hearing from all of you on how we're going to do it.
we'll touch on that definitely. But let's hear from Michelle, a literal titan of public health.
Sure. You know, it's a hard act to follow Amy and Sten, but let me try to engage a little bit with the, with this question about public health having lost an important part of itself in the last century. I think many of the principles of public health still endure from more than a century ago, meaning specifically that much of what drives us in public health today, continues to inspire us to want to do the very necessary work that closes the gap between what we know and what we do to improve the health of all, particularly the most vulnerable. And I think there's always been a cadre of people in public health who are strong advocates in addition to being academics. But the practice of public health really has been attenuated a bit over the last 100 years. And a lot of that, my fellow deans have touched on some of the external factors and even internal factors that have driven an attenuation of academic public health engaging in the practice of public health. This concern, was very eloquently expressed over 60 years ago by two giants in the field, Milton Terrace and Abraham Lilienfeld. And they lamented that as academic public health emerged and became stronger and more vibrant across our elite institutions, they were becoming technocratic and moving away from the real seed corn and the why for public health by dismantling strong relationships with local and state health departments. And in a lot of ways, we are living the legacy of that untethering of the practice community of our discipline. And when you ask yourself why that untethering occurred, what underlined it, it really does come down to the way public health schools, particularly the academic oriented public health schools and programs that covered the breadth of discovery science, knowledge generation, as well as practice. And as the funding model became more soft funding, more competitive, NIH-based funding, the balance between the science of public health and the practice of public health started to get out of line. All that said, I think there are opportunities to reconnect and re-engage with the why public health that brings practice back to the fold. And I think that is happening in large part because of this pandemic, but also because of massive civil events such as, our sitting in place in quarantine, watching the last minutes of George Floyd's life, which raised a consciousness and an awareness around Black Lives Matters and brought a movement to a scale that we had not seen before. So I think this is reawakening that activist bent in public health, because as you have already touched on, Ed, in your article, there is a movement more towards that activist bent that this pandemic and current events have brought forward. So what the pandemic has also done is also laid bare the fact that there's an incredible amount of unfinished business in equity, in environmental health and safety, but also it brought forward a very strong reclaiming of a truth that many of us knew in public health, but had not been embraced by the public. And that is the legacy of racism is in fact a public health crisis. And I think that reckoning will bring back more reformist behavior, more practice and problem solving and activism into the public health space. I also think that we're seeing some very important additional events that's driving activism and a commitment to practice in public health. These current events include appreciating the magnitude of the mental health crisis, as well as the calamitous effects that we are experiencing, not hypothetically, but real, with climate change, especially the environmental injustices that we're witnessing. So I think we're at an inflection point in public health. And I think that we will need to ask the questions about what is the right balance between knowledge generation and knowledge translation and practice in academic public health. And how do we build back real connectivity between the academic institutions of public health and the communities of practitioners of public health. And then finally, I just want to bring forward a current event, a recent event in around labor that comes back to one of Amy's opening points. What just happened with Amazon Fulfillment Center in New York City, the first Amazon union in the United States after a couple of efforts. This is a public health victory. It happened because of the work of two men who were explicitly embracing and expressing public health values, such as worker safety and environmental equity. So the question for me is, will we in public health, be bold enough to embrace and embolden this public health victory and others like it that we have to accrue as a result of the awakening that the pandemic has brought forward, and create a more explicit intention to align with labor movements, civil rights movements. Over a half a century ago, we invested in creating a Center for Health and Human Rights, maybe 35 years ago. And, that is an expression of explicitly embracing human rights and activism in an academic center. But the history, the capital fund flow has really made it difficult for a lot of the social determinants of health and more activism in public health in academic settings, which are soft-funded institutions, really set an agenda and drive an agenda without falling victim to the external forces of how those funds flow.
Right.
Apologies to everyone watching on the feed. Sorry that there are audio problems today. So thank you to all three of you for these great comments. One thing I really loved about the points that all three of you made, I feel like often public health has this kind of victim narrative around it. Like we lament the consistent lack of funding, the chronic underinvestment, but all three of you have talked about the fields taking much more of an active role in sort of re-empowering itself. And that's one of the themes that I touched on in the piece, that if the field has truly had an active role in its own marginalization, then it must also have an active role in its own re-empowerment. And Michelle talked about several of the factors that might push the field towards that sort of racial reckoning and all everything that's happened over the last few years. But I also hear that there are factors that skew towards timidity, from the political marginalization. Sten talked about the lack of funding, just the structures of academic institutions and the incentives around that. So I guess what I'd love to hear from the three of you next is how can public health aspire to a greater purpose? Like what can it do to more actively push the vision that all three of you have talked about in this environment when it is politically and financially limited? How do you regain power from a baseline of weakness is not quite the right word, but it is that, like of disempowerment? What does the field actually do next? You're nodding furiously.
There are moments in a variety of disciplines which can be taken advantage of, and this is our moment. With devastating mortality worldwide and financial costs that literally boggle, when we're talking in trillions and trillions. The COVID pandemic has unearthed the public health weaknesses that we have allowed to grow in our systems, in our societies. And people who saw the pandemic influenza plans of the CDC that were revised in 2017 and just pushed them aside are now starting to reread those plans and realizing that if they had acted in 2018, we would have been so much better prepared for 2020. And there is serious conversation about pandemic preparedness. Now, the cynics will say, sure, it's a little bolus, and by 2024 we'll be back to normal, but maybe not. I would say the same for climate change. The data are now like a tsunami washing over us, where at every turn, everything is worse than the worst estimates that our climate change scientists have been, if you will, the 95% confidence interval is always at the upper end. And whether it's the calving of chunks of Antarctica the size of the state of Rhode Island, or whether it's historic declines in snowpack in everywhere from California to Alaska, we are up against a crisis circumstance. Michelle alluded to the impact of the filmed drama of the death of George Floyd, the film drama of Ahmaud Arbery being tracked down by vigilante racists, and on and on. So at many different levels, I think 2022 is different for us. And it's going to be up to us to seize the opportunity for mass education and appropriate political and economic response.
Yeah, Ed, thanks, Amy. Let me add a bit to Sten's response, but also, say, Ed, it might sound like, victimhood, but I think for me, it's just having a clear-eyed understanding of what our challenges are. And, I think the challenges are, limited funding to address the scope of the work that we have ahead of us and we have to do. It's not as though we have vanquished the infectious disease threats and then turned our resources towards addressing non-communicable diseases. We're sort of fighting the battles on two fronts because we've never really been able globally to address all of the different types of public health threats that emerge. So we find ourselves having the way public health has evolved and global health has evolved, having to do more for more with less because the proportionality of the importance of public health to all of civil society has not been met with the kind of support and funding. So it really goes beyond victimhood. But I want to engage with your question in another way by saying, one of the things we should all appreciate when the world's economy came to a full stop for this pandemic, that public health really has to be everyone's business, not just the people within public health, because public health is everybody. It is everybody's health, from the individual to the family, to the community, to the nation, to the world. And that interconnectedness has to be reckoned with in ways that we understand where to place public health in society. And in my view, and I'm biased, I've spent 40 years of my life in public health, but I think what we have to do is make it clear to more people that public health is the seed corn and the bedrock of civil society, period. When that is reckoned with, then I think what we have to do, we within public health, we have to find ways to create radically brand bold partnerships. And I don't mean the kinds of partnerships that will enable extraction and exploitation of the public health brand or principles, but one that truly integrates public health principles and approaches in all sectors of society. So I've been arguing that one of the things we must do, because it's in all of our interests, no matter what sector we're in, is we have to support the building, the maintenance, and the execution of public, private, and academic partnerships that will drive the closing of the gap between what we know and what we do to protect, promote, and preserve health. I think it starts with partnerships that fully understand that the work we do is essential to civil society writ large. And public health has to lead the way and realize that all sectors must be involved in the work of public health.
So, Michelle, as you were talking, I was reminded of a quote from Alice Hamilton, who was a physician and later reformer in the 19 teens. She said, "Government is nothing but ourselves organized." And so I think you're hitting on this point, Michelle, of if we answer this question about what do we do in public health, we have to think about the different domains within public health lives. So it lives in a civic domain that we all need to be engaged in. It lives in the Amazon fulfillment stations across the country, but it lives in health departments. And I think it really is important at this moment in time to understand the tremendous pressure people are under, and not think of it as victimhood, but think of the people who are staying there, staying in conditions where they may be working under a government that they don't agree with, where there may be a disconnect between a health department and a public health orientation and a legislative orientation. That's a remarkable act of courage. And I think as a community, we need to support people who are maybe encountering being trolled, being doxxed, being accosted after work in their yards. We need to counter that with support. And I think that we need to think about the role of the university community. And I see it happening, but I think our role is to change the conversation. But that first and foremost means being part of the conversation. And that requires an institutional change. So it requires people like me and Michelle and Sten saying, let's make sure our guidelines for promotion and tenure value community engagement, that we value political engagement, not necessarily thinking about politics as something different from partisanship. That we value the time and effort that it takes to build those relationships, to write those op-eds. Maybe one in 50 is going to get accepted someplace. To taking the time to testify, to write letters to your congressman, and to engage. We need to value that engagement in the public conversation as well. But I think again, we think in terms of those. We have to think in terms of those different audiences, those different sectors.
Does anyone have any questions from the audience?
Thank you. My question has to do with in one aspect of American public health where we are the lowest in terms of the developed world, which is maternal health. And so dismaying to see the recent stats that our maternal mortality rate increased 14% in 2020. Where do we see our response to this heading?
I'll give it a shot. We have persons in society who are disengaged from antenatal care. If you're an immigrant without documentation, you may be afraid to go to a clinic. If you have a mental health problem or substance use problem, it may be a very unfriendly health system for you. And we don't have very much that's grounded in the community. So the notion of the community health worker whose job it is to help folks access care get care, not be afraid of care, we are severely underdeveloped in that arena. And when you go to Europe, you'll see that the immigration system will talk to the public health system, and if you're pregnant, you will have a home visitor. If you have a child under the age of 2, you will have a home visitor. This is seen as innovative in the US and being reinvented state after state, jurisdiction after jurisdiction. When the funding goes away, the program goes away. So this concept that the health system should be grounded in prevention is not where the US is strong. It's the old adage, if you've got a terrible disease and you have health insurance, you're best off in the US. But if you want to avoid getting that that disease, or if you don't have health insurance, you're better off at 34 other of the OECD countries, because they are far more focused on prevention and reducing barriers to care. So I think for maternal mortality, we have subsets in society that are at higher risk, and we should be engaging those populations at the community level to try to facilitate their access. And certainly that will be the only way, honestly, that we're going to. It's not a problem with the quality of healthcare, in my judgment, and I don't think it's a problem with women who are wanting and willing to get care. But when there are roadblocks, when there are obstacles, be they physical, transport, psychological, legal, we have to have a problem-solving attitude and tackle it from those sort of social roots.
Yeah, I would argue that some of that problem solving that Sten is alluding to needs to happen long before a woman is pregnant. It really is, you know, all of the factors that drive and lead to the disproportionate risk of infant and maternal mortality begins way before we even think about accessing prenatal care. These are the social determinants, and it's an intergenerational effect of how women and girls are treated in society, the access they have for housing, safety, mental health services, food security. All of these factors upstream of that pregnancy contribute to the health and wellness of reproductive age women that put them at risk then for clinical medical complications that result in their increased risk for maternal mortality or infant mortality. So I think one of the things in answering the question is to think very holistically, think systems wide, and really begin to appreciate that healthcare really is only a tiny fraction of the attributable factors that contribute to successful reproductive outcomes, and not fall in the trap to think that it is the healthcare sector alone that is playing a role in the health outcome disparities that we're seeing.
So let me follow that on with a question. So all three of you have spoken about the very expansive nature of public health. That we talked about things like climate change, about racism, about all these upstream factors, systemic problems. I think one pushback that I hear sometimes to the values and the ideas that all three of you espouse is that the problem is simply too big, that you're dealing with issues that are society-wide, and that surely are beyond the remit of the field that itself has been subject to underfunding and so on. So how do you, what would your response be to that? Like that all of this is, that this is too big, or we are dealing with problems too big for public health to address on time?
I think that's the, can you hear me? I think that's one of the challenges we've been dealing with in this field, even in some of our moments when we were most effective, most visible, most embraced. So I think in this moment in time, though Michelle, I agree with you when you say we need to think holistically, we need to think structurally, we need to think in terms of systems. I think we also have to think politically. And I think to take your question, I think we have to ask, what's the lever that we can most likely pull? What are the values that we can attach to, that we can activate in this partisan climate that are going to be most likely to get some action that maybe is not going to get social reform? We're not looking at for the revolution, but that's going to get some action. I think it's kids. So I think it's as important as it is to think about what happens to mothers before they become pregnant. We have in this country a history of wanting to do things for children and for infants, because that's the one group that we don't argue, well, they don't have choice. They can't exercise individual responsibility. So, and that may not be the right answer, but I think that's how we have to think. What's the lever that's gonna let us get a foot in the door, that's gonna give us a wedge to begin to move policy in some fashion. Children have been, and infants have been a successful wedge, and that's one of the places, ironically, that public health has been able to sustain some effort and sustain some success over the course of more than a century.
Michelle, did you want to answer that question before I go to the chat?
No, I think Amy picks up a point that's really important. One of the guiding principles of public health is really to design systems and processes and practices that protect the most vulnerable in our population. And children, we've seen time and time again, small investments that are made to improve the life and well-being of children have massive returns on investments. But I think your point about how expansive and massive and broad of a remit public health is very true, and it is expanding over time. I mean, when you think about how the one institution in public health, the CDC, has had to respond to the evolving threats to population health over time, founded largely to address tropical diseases, and then to address the emerging challenges of non-communicable diseases, where they're multifactorial, non-clinical public health measures that needed to be put in place. And then, having to deal with climate and violence and threats to gender equity. The playbook just keeps getting thicker. And so the field of public health has had to expand, but not necessarily with all of the resources and the awareness during times of strain to do it gradually. So it has been this, you talk in one of your articles, Ed, about the cycle of panic and neglect. And it's sort of how public health has grown too in response to these moments of panic. And, I worry that, our remit is quite large. I mean, now we've got public health people managing the health of populations in conflict zones. Well, we've been doing that for a very long time, but sometimes, the community of legislators and administrators forget how expansive public health remit is. And because of that, we end up being stretched too thinly. We sometimes fail to recognize others who are under the public health umbrella. We tend to become siloed in our disciplines, and we really forget that the state of play is as broad as it truly is.
And Greg, do you have any questions from the chat?
Yes, I do. The question that I'll do the first one. Does anybody have any brilliant ideas for how to engage in the important politics of policymaking, public priority setting, routing, tracking, polarization, local practitioner here, and the backlash of years?
I think it requires, it requires very deliberate and careful communication and framing, thinking about the values that you're encountering on the other side, thinking about your values, thinking about the evidence that you have that's going to speak to those values, and not flip a switch that's going to have somebody not hear you anymore. But I think it requires, it's a one of the competencies in public health education, but I'm on the framing in the Future 2030 steering committee for the Association of Schools and Programs of Public Health. The theme that keeps coming up over and over again is we have to actually educate our students and our faculty in good communication strategies and good advocacy strategies. And it may not involve giving your favorite evidence. It may not involve always saying the thing you want to say. We have to say the thing that somebody else needs to hear, and that requires training and it requires some discipline. And it's something we have to bring to our field.
You mentioned earlier, I think it's related to the chat question, the broad nature of public health challenges. One could say the same about field of medicine. And we don't ask a doctor to be an ophthalmologist and an orthopedist and a pediatrician. And I mean, we have, we divide and conquer, and take a look at the CDC winnable battles list. Very carefully thought through 10 things that we could do in the United States that would have a disproportionate impact on survival and alleviating human suffering. And I think in public health, we can do that. We can take our various disciplines without siloing them. We can still have our areas of expertise. So I've been doing infectious disease epidemiology for 40 years. I was in my comfort zone, I felt, with COVID, and I felt I could make my contribution. But that doesn't mean that I don't understand somebody tackling overweight and obesity problems in our schools, and working with urban planners to make sure that sidewalks are available, and that after school activities encourage physical activity, and that there are 100 nuances in obesity prevention control that have, you could say, nothing to do with public health as a discipline, but have everything to do with the vision that this has to do with sedentary lifestyle and diet. And whether it's food deserts, working with farm to table folks in your town and with small bodega owners or whatever, whether it's urban planners, whatever it is, the public health person should be at the center of the vision, I think, for those sorts of partners.
Greg, did you want to?
I fully agree. I fully agree with Sten's point. I think public health is as multidisciplinary as any other field. And I think one of the best ways that we can leverage all of the talent that comes under the public health umbrella would be to engage in place-based problem solving, where one could really easily begin to point out where the different disciplines, when orchestrated in problem solving, can come together and have almost a flywheel effect of impacting all of those social determinants, if you will, that are drivers of 80 to 90% of the health and well-being of populations. I think if we were to move back to a place, we within academic public health, where we started to re-embrace the principles that the population human laboratory, the natural laboratory, if you will, is really the classroom and the place of operation for public health academics and professionals, I think we would start to begin to connect back with that multidisciplinary narrative of our discipline, but also engage with that problem-solving side that brings people to public health in the first place.
Right. One more.
That's not gonna work. If I just project, can people hear me?
Yeah, this one.
Okay, thank you so much for this amazing event. It's wonderful. I'm a Yale School of Public Health and School of Medicine faculty member, also a Yale graduate. It's really been so inspiring to hear from these deans about rebooting public health. I wanted to put forward an idea for a different way of teaching altogether. Because we've heard so much already, as Dean Williams just said, about all the different disciplines that are integrated in public health. And we've heard today, there's history, there's biology, there's microbiology, there's political science, there's computational, all kinds of things. What if we taught public health in an inquiry-based approach, where we taught classes that were built around questions like, why is it that we are seeing such high rates of infectious disease and non-communicable disease around the world? Why does global and public health funding flow the way that it does? For that class, we could learn about history, colonialism, neocolonialism. We would learn about what happens when grants are administered and why it makes it hard for some of the lower power recipients in these kinds of situations to have a voice. We could even just do a class on something like, why does HIV with 9 genes cause such different outcomes around the world when humans are 99% genetically similar? Thank you. But I think it's worth a response. So I do think that the field of public health has been moving in that direction. And there are a lot of schools that have begun to integrate the core curriculum and try to take things out of silos. I can tell you, everybody who weighs in on the Framing the Future 2030 discussions that we have says some version of that very same thing. So I think that's the direction that the field is going. I do think it requires us to think differently about faculty, because the history has been, and Michelle made this point, that we hire people in disciplines and tenure and promotion and certain rewards. And what we need to do as a field is to think about hiring people with the expectation. Yeah, you still have to be an expert in your discipline, but you have to be able to talk across disciplines to problem solve. So I think it requires thinking about who we hire, and it requires giving education to the faculty that we have now to enable them to do that. And that's something that I've been involved in all 3 of the institutions I've been in. It's not always easy work, but it's the direction the field is going, and I think it needs to, the voices continue to push us in that direction.
Yeah, if I may, I would add to Amy's great response there to say that one of the ways we're pushing in that area of reimagining teaching and learning in public health is through using the case-based methods. And sometimes maybe the question that you want to use to spark the teaching experience is not why, but how. How can we move policymakers to write legislation to curb the distribution of sugar-sweetened beverages? How can we encourage, support, and enable policymakers to write policies that would close the gap between what we know about improving indoor air quality and the status quo of not doing so? How can we use a pandemic to encourage people to understand that indoor air quality is as important to public health and people's health as going to see a primary care physician, once a year? So I think along the lines of reimagining how we teach and learn public health might be to also think about asking the how do we make changes to promote health, and using the case-based method as a way to bring the disciplines together and literally illustrate the many different disciplines that have to come together, the skill sets that have to be brought to bear to drive the public health principle and practice on scale, particularly in legislative quarters.
I like the, I really appreciate the tying all together of education and action and activism, the themes that you talked about throughout this session. Like often we prioritize the former and forget about that translation aspect. And I guess just on that note, we are out of time for this session. Thank you so much to all three of you for joining us today. I hope you enjoyed this.
Thank you,
Thank you, guys.
Yes.